Okay. So with this whole concept for central line, before we go over that, let's kind of just review your peripheral IVs because you guys have been out of it for a second. You guys had OB, you guys had psych. So it's been a while since we were in med search. So just for review on your peripheral IVs, I have this written down here. Your 18 gauge, that's the green one. It's smaller the gauge number, the bigger the catheter. Bigger catheter allows you to have faster infusion and it allows you to be able to get blood in there without breaking down the red blood cells. The 20 gauge is the pink one. For the most part, it's about the same as the 18. It's easier to place, but it's not going to be as good for faster infusion. The 18 is the biggest, not the biggest one, but it's the most standard big one. So it's going to allow for faster infusion than the 20, but for the most part, the 20 is still very good for the same cases, for high flow of IB fluids and for blood transfusion. Your standard IV that patients when emergencies are not expected, so like on like actual med surg floors, maybe like the blue 22, and then the 24, which is people that have smaller, weaker veins, older adults or children. And this one's going to be a lot harder for you guys to get like a fast flow rate and things because the catheter is smaller. So in general, you're aspirating and flushing up to the policy. So some places might not really care if you try to aspirate blood out or not. But it's worth noting that if you cannot push it through, it could be a clot, and then forcing it too hard could dislodge it. And it's kind of the same concept as like a DVT. If you have a clot in your vein and you're pushing it back up, it might go back into circulation and into the lungs. So that's something to think about. Although sometimes it is, especially if it hasn't been flushed consistently, sometimes it will be a little bit hard to push. And if you put a little bit of force, it goes on just fine. Sometimes you do have that catheter just kind of in the corner of the vein, kind of like your NG tube, where you can have it just kind of just chilling on the stomach wall. You can have it chilling in the vein wall. And so doing a little bit of pressure is just kind of getting it out of the way. But if you absolutely have to very hard push down, then don't push it down and you'll probably have to get a new IV, DC it, and put an IV somewhere else. What I do want you guys to be able to answer is kind of like what conditions would you want multiple IVs and large bore? And we'll kind of, whatever you guys say, we'll input it in wherever column it goes. So for surgery, okay, yeah. Surgery shock. So I like that surgery shock. And then kind of same thing here. Potentially. The idea is kind of there for blood transfusions, yeah. So it kind of goes like that, blood transfusion, high flow, LND, yeah. So again, that kind of goes with shock, blood transfusion, because the patient can risk losing blood for kind of for both of these. Honestly, it's for a lot of the same use cases. Something that I think Kaylin and I would always kind of say would be like maybe patients with seizure precautions. Oh, can you hear?
Anything patient's gonna crash, put two IVs. The
Yeah,
biggest you can get.
yeah. So again, the same concept of they're seizure patients. If you guys recall what's it called? The one where they keep seizing. Yeah, status epilepticus. If that first IV is not good, then good luck putting good luck putting a new one into the patient while they're seizing. Yeah, you could do it, but like it's not recommend. Yeah, yeah. Extremely low BP kind of goes with the shock. So different types of shock. Yeah. But yeah, you guys kind of get the general idea.
Yeah.
Here it's just a review of your peripheral IB complications. This is all from like what, semester one? Thrombophlebitis, so the red hard vein, the infiltration, extravasation, some extra ones that then weren't gone over too much, just like hematoma, speed shock, so too fast with the IB pushes. You'll go over this a bit more next semester though, but this is kind of there to keep in mind. Yeah, that's just kind of like the overview of the peripheral IV. And so let's actually go on to central lines. What are the reasons to want to insert a central line as opposed to just kind of maintaining your peripheral line? Okay, so high or low pH. Okay. What kind of medications might have that? Vesicants, yeah. So if you're putting in vesicants, for sure. Chemotherapy. So let's put long-term IV. So chemotherapy is long-term. TPN, yeah, TPN's very high osmolarity. So having that go straight into the heart where it can defuse it really quickly is a good idea. Long-term use, yeah. So long-term IV. So maybe if they're being DC'd home with antibiotics. Good. The only other one, sometimes you'll see people, yeah, literally. If they're a difficult peripheral stick, I know the policy of this at UCI Lakewood. It's supposed to be um, a nurse gets two tries, then they have to get a second nurse. They get two tries, and if they both fail with their two tries each, then they get someone to put a pick line. So yeah. All right. So what are the list of the types of central lines? And then when you guys are in the lab, there are little models that kind of show all of them. And then we'll talk about each one individually once we kind of write them all down. So we have a pick line, okay. Subclavians usually like, that's where you put it. A lot of them kind of go there. Porticath, so that's like the porticath. Pick line, tunneled, non-tunneled, yeah. Oops. Tunneled and tunneled. The implant pretty much is the porticath. Yeah, implanted slash porticath. That's the same thing. Mm. Yeah. And again, there's like a little model that you guys can see in the skills lab that kind of shows you all of them. Some of them and then some of the mannequins just have a pick line. I do have a picture to kind of go along with it. So here's kind of the idea, because I get asked a lot, what's the difference between a tunneled and a non-tunnel? How can you tell? Make that a little bigger, I suppose. So you guys can kind of see here, the non-tunneled, it's going to be, and that's a Clavian vein. Um, but the main thing here is that it goes in there, it makes it all the way to the heart, and it just sticks out like that. It's sticks out just like a normal IV would, just out of the skin, versus the tunneled, which is still going. If you actually can see here, the cannulation site is actually the same for both. Except the tunneled has a little bit of space here where it's surgically placed underneath um, some of the subcutaneous tissue and then placed outside after. So the idea behind doing this, or actually, I'll ask you guys, what do you guys think is the advantage, or what do you guys remember is the advantage of this tunneling going, going there? So they're both start here for the cannulation, but then they're surgically placing this under subcutaneous. Yeah. Yeah, so pretty much, so yeah, so compared to a non-tunnel, this is going to have a less lower risk of infection. So the idea would be the part that's actually sticking out and gets accessed, you see here, um, has kind of to go under this sheath before it can actually go into circulation. So it's a lot harder for stuff like that to take place as opposed to here where this cannulation site stuff that gets on it will immediately just go into circulation. Here, things that go on it still have to make their way through the sheath, which is not as likely. All the fat, yeah, that's like surgically placed under there. So yes, it's going to be low risk of infection. You're right. It's going to be harder to kind of come out, harder for it to become dislodged for sure. Yes, decrease infection, not as much as inflection. Yeah, that's pretty much it. Is there an advantage to a non-tunnel that a tunnel doesn't have the advantage of? Yeah, it's easier to place. Why is it easier to place? And I did mention it. Yeah, easier to place. Good for emergency. So what is the tunnels required that makes it harder to place and take longer that we can't use it for emergency situations? Yeah, you need that's a disadvantage. So yes, requires surgery for placement and removal because you have that surgically placed sheath underneath the fat. You can't just do that. You can't just do it super quickly as opposed to a non-tunneled, which you can just kind of place it in. So for emergency situation, they'll do the non-tunnel just because it's faster. You don't need surgery to put it in. You don't need surgery to take it out. Tunnels need surgery to put it in and out. Yeah. So if you heard Kaylin, she's saying, yeah, Kaylin's a little far out. She's getting juice or something. Yeah. But yeah, she says, that's it comes with a price though. So like, yeah, sterility. So this one comes with the higher risk of infection. You're just kind of putting it in, so higher risk of infection, and then something else that we'll talk about for you guys to keep in mind. And I think Anne mentioned the subclavian. So these are going to be inserted into the subclavian. And kind of like in the picture, you can see that's the same cannulation site. So this one's also inserted in the subclavian. Okay. But your main thing to focus on is these things right here. That's the difference between them. What else, when it comes to both of these, I guess, what are some complications? And we'll talk about these two later, but yes. Yes. So Kaylin's asking which one has the highest risk. Yeah. So PTX is pneumothorax.
The other people were using shorthand and now you doing it.
Yeah, but I put it in parentheses. See? Yeah, non-tunneled. Why? Because we're just, oh, well, yeah. Ah, she hit me, guys. Help.
Yeah.
Eh. Remember what we said the use case was for the non-tunneled? It goes into subclavian. What else? When is it typically being placed?
I'm helping you guys. 911. Yeah, I mean essentially.
Yeah,
Emergency.
essentially emergency. Yeah. So the doctor's playing Yahtzee. He's going Yahtzee, boom, slide the non-tunneled in there. So, so a little bit higher risk of pneumothorax. So yeah. So Anne's talking about thrombophlebitis. So which one has the highest risk of thrombophlebitis? They'll technically do, but there's one where you technically are supposed to, measure something. It's the PIC line. The PIC line. You gotta measure. Yeah, you measure the area. So measure this arm circumference. Yeah. So this one's gonna be higher risk of thrombo. They all have a risk, but the PIC line is the highest risk. And you're going to want to measure arm circumference. And if it's suddenly bigger, you probably I don't think they got massive gains in like a day or two, so it's more likely that they have a clot there. But yeah, that's a possible complication there. All right, so let's talk about the pneumothorax. So what is something that's done in order to kind of look at it, look like assess for it? Yeah,
Chest pain.
sure.
Suppress.
Shortness of breath. Okay. So we'll say chest pain, shortness of breath. Yeah, you could probably have hypertension that then becomes hypotension as they're decompensating. Yes, tachycardia. Besides shortness of breath with tachypnea. Okay. So that's your physical assessment. Is there anything else that can be done before or after or during? Probably after to kind of check. Yeah, that's a good one. Kayla mentioned this too. So equal chest rise. Well, sorry, you know what I meant, right? Like I was like, that's normal. That's the normal one. I guess, but yeah. Chest X-ray, yeah. So that's something for you to keep in mind. That's probably going to be a test answer for sure. Like for sure, right? You're gonna be doing a chest X-ray to rule it out, helps rule out pneumothorax. Plus, it also confirms the placement. So it works two ways. So all right, so we're gonna go here as this one's risk for highest, put highest risk for PTX, pneumothorax. Patix, risk for pneumothorax. What about PICC line? Does the PICC line have a risk for pneumothorax? Yeah, not particularly. So what is a PICC line? Do you guys know what it stands for? Peripherally inserted central catheter. Yep. So this one, if you look at a PICC line, if you see right here, this one's probably better. You see here from this picture, enlarge. Yeah. Peripherally inserted, literally exactly what that means. This is in the same position that your peripheral IB would be placed in. The difference is a peripheral IB, um, the catheter itself would probably stop where my cursor is right here, where it says PIC. That's probably where the peripheral IBs would stop. But the PIC line is still a central catheter, meaning it's actually going all the way into the heart, all the way through. Okay. So that's the difference between a PIC line and like a peripheral IB in terms of that. So this is in fact, yes, peripherally inserted central line. Okay. So the reason for that is because it's inserted peripherally. So very unlikely. I don't know how you could even mess it up that bad to the point if it happened, but it's not as likely. You have to, I don't know what the doctor has to be doing for it to happen if it happens. Would you still want to do a chest x-ray with a PICC line though? Yeah. How come? So exactly. So you're still gonna confirm placement. So chest X-ray, confirm placement. And sometimes you'll have these pick lines be guided by ultrasound. So because you're gonna not just insert it in and forget it like an IV, you're gonna be inserting it and then snaking it all the way through the vein and then making it to the heart. So having that guidance is pretty much needed. So you can actually get it in the right way. The other ones, you can see the catheter is a lot shorter because you're also inserting it from a much closer location. But it also does mean you're having a higher risk of um, I imagine you have a higher risk for like heart, like some sort of like inflammation to the heart. Like if bacteria does get in there, you might get like yeah, it's directly in there. The PICC line you can still of course get infection, but yeah, with all of them.
Yes. There, hi. Good morning, everybody.
It's not morning.
Good morning, my always.
hmm 14, not including me. Oh, no, that'd be crazy. That's more than the whole class right there. 44. Yeah. Measure the tubing. Yeah, so that's something to do with all the peripheral lines. So how much is sticking out is something to keep in mind. Did you guys go over the central line dressing change skill as a skill? Yeah? Cool, cool, cool. All right.
Oh no, you had a central line and it got pulled out a little. It was at 0 centimeters and now it's at 5. What are you gonna do? Oh my gosh.
I don't know if you,
I have my Coke soon. Don't put it back in.
yeah. So what about if it does the opposite? What about if the that number instead of like 3 centimeters sticking out, it's sticking out 1 centimeter instead. Yeah. Yeah. So remember, as a nurse, your pull-out game is strong. So that is how you remember. You can pull out, but you can't push in. Ow. The lock? LOK. Oh, oh, I said you can your pull I said your pull-out game. Oh no. You said the the pull-out game is strong. So that's how you remember that you are allowed to pull it out, but you're not allowed to push it in. I'm just talking about tubes, so I don't know what Caitlin's talking about. So so I guess I'll include that under here somewhere. Ba-ba-bum. It's not really a complication, but let's call it. I guess probably under considerations more.
Yeah, considerations.
There you go. Yeah, there's definitely more, and we will talk about it. We're kind of doing it in an awkward order. Yeah, it's okay. Okay, I guess another thing I can include here, good for emergency, also it's shorter term, which is also in the picture, but short term. And this one we said longer term. Pick lines also for longer term. And let's talk about the implanted catheter. What do you guys know about that one? Oh, really? Yeah, definitely good for this is like the most long term. Yeah. Yeah, this is like surgically inserted in. Yeah, the Huber non-coring needle.
It's great.
Oh my God. Yeah, so you will, yeah, flushing with heparin is good. Huber needle, Huber. Yeah. Something else I'll mention because I guess I forgot to mention it is for the pick line. You do have precautions. So what is your precautions with the pick line? So if the patient has a pick line, you're gonna go do your vitals. Yeah. So no BP on the arm that has pick line. We're also going to try to reduce the mobility on that arm to not kind of mess with it and no heavy lifting. That's pretty much it for that. Yeah. Anything else? No, for sure. Yeah. I'm trying to think what else we can do. Probably considerations we can talk. So what else is a complication? We pretty much honestly what we have written down, that's pretty much all you're really going to need. Your focus is a lot on this complication stuff, a little bit less than knowing the absolutely everything there is to know about each central line. Just kind of getting the rough idea. So really focus in on infection pneumothorax, infection pneumothorax, here thrombophlebitis, and the measuring the arm, and things like that. Focus a lot on the complications. So what other complications? Well, we kind of already mentioned it, all right? We mentioned infection. What's that one called for central line specific? The CLAPSI, central line associated. Uh, what's the B actually? Blood something infection. Blood special. Hold on. What's the B stand for? Bloodstream. There we go. What? Oh. So, typically 2 to 3 days after infection, if they have a fever the same day, it's probably something else. So always keep that in mind. That's usually how long it takes. And I do recommend that you learn the SAFE acronym that Mr. Robbins has on his lecture. So we'll just go boom. Scrupulous hand hygiene, aseptic technique, vigorous friction to hubs, ensure patency. Okay. So that's for CLAPSI. Any questions so far? There's one more complication we'll talk about. There you go. Air embolism. So I was gonna say, what about when you're pulling it out or when you're taking the thing out? I don't know why the font's different. What font is this? Arial. Let's go back to Arial. Okay. Hold their breath and bear. Lay them flat. Yeah, lay them flat. Hold them bare. Not to talk slash laugh. Great. Yeah. So let's talk about, or let us kind of write this down. Can occur when DCing the line. DC maneuver should be this. Have them lay flat. Oop, there we go. There we go. So all that stuff. This would happen when they insert the line 2. Hmm. Does the air embolism happen when you insert it in 2? I imagine it can. But let's talk about the signs and symptoms of an air embolism. You'll notice it's pretty similar to another thing.
Oh,
Yeah, shortness of breath. What else? Yeah, so we'll kind of have a hypertension that can lead to a hypotension. It's like the hypertension on the initial struggle, hypotension as they decompensate. Chest pain, yeah. HA is headache, maybe. Yeah, tachy. You notice this is very similar to a pneumothorax. Very similar signs and symptoms. Yeah, and we'll kind of go with distant, diminished lung sounds. But you'll notice pretty much similar, almost identical symptoms to the pneumothorax. Best way to differentiate. I mean, your chest x-ray goes a long way, but also kind of like the situation at hand. Like, I mean, in the scenario, you'd probably do like rescue interventions, get them out for a chest x-ray, just to rule out pneumothorax or tension pneumothorax, and then kind of see where they can go from there. Because they have little similar symptoms, so like the initial intervention is going to be the same thing. Right? So like the goal isn't so much to like immediately within a snap second differentiate between them. It's really just to deal with the signs and symptoms, which you kind of do the same way, then get like call a rapid. So maybe head of the bed up, O2, call a rapid, O2, see what's going on. They'll probably get sent out. Um, maybe quick a chest x-ray to see what's going on. Maybe I think one of the things with the air embolism that probably will not be there with the sorry, other way around. Something with the pneumothorax that is probably not going to be there with the air embolism is the difference in the chest rise. Because the pneumothorax is going to be like one side of the lung having that difference in pressure or having the fluid. So I would say probably the chest rise is probably like the main differentiating factor. But either way, they'd probably go through a lot of the same stuff. Okay. So now, I guess we do have like a little thing I can go over for like specifically what do you do. Um, so for air embolism, again, it's also kind of think about your context, like what's more likely, you can technically have like spontaneous pneumothorax, but it's like if you just pulled out the catheter, for example, and they're feeling these symptoms, it's probably the air embolism, right? If they just inserted a catheter, I guess that's probably where that might be like the differentiating thing might be more important, but they're already getting the chest x-ray anyway, so that's kind of where all that goes. So again, situational based, and then probably the chest rise is a way to differentiate. But for interventions, he should have gone over it, but do you guys remember? Trendelenburg and on left side, yes. Good job. Exactly. So this is what you should do then. All right. This may or may not be an answer. Not gonna lie. It feels like it would be. I don't remember, so like I'm not like hinting. I'm just saying like it may be. I feel like it would be. But oop. Heh. Nice. Why only one? I took like four. Bro, I almost took a Foley catheter. I was like, I'm gonna take a Foley. I'm just kidding. Allegedly. Yeah, that's pretty much what other community. So we talked about that. We mentioned this a billion times, except tech technique. We mentioned chest X-ray to confirm placement and rule out pneumothorax. So all the stuff we talked about, things like dressing changes, I would say that's Q 4 to 7 days or per policy or PRN.
You know, by a thread, like how all of us are in nursing school. You should replace it.
Any questions so far? Was it clear? Any clarification needed? Clear as mud. That's not a good thing. He's joking, right? I don't know what J/I means. I think that means joking. I have no idea. Oh, okay, okay. April. Oh, it is April Fool's, huh?
It's time to troll.
Yeah. Now I'm gonna give you guys this. Blam. Boom.
Oh, I forgot that chart existed.
Yeah. So
That's a lot.
it's a lot, and a lot of it is pretty extra, but it's more information that might help you. But again, what we went over here is probably all you really is, for the most part, what you'll need. Here is just like extra stuff if it helps you. So complication, assessment, prevention, intervention. So a lot of extra stuff. All right. Is it?
Bro, I was holding on by a thread.
No.
Yes.
All right. So next, let's go over blood. Some of the blood basics.
I got the credit card, y'all.
What?
Let's go.
All right, so let's quickly go over blood. So compatibility, what gauge is appropriate for blood, or gauges rather. Yeah, so we're gonna go large bore, which is 18 or 20, or what, or you can even go 16 if you can find one. Yeah, 16 gauge if you don't like them. IV fluids. So typically, the blood, I think they probably showed you it has like that Y, little Y tubing. So it usually has one pouch is the blood, unit of blood, and the other one is IV fluid. Which one? Yes. What about D5NS? Does that work? No. Yes. So yeah, only exactly NS.
Creates like little crystals and stuff.
Yeah. Yep, it would. Yeah. Even D5NS can lead to crystallization of clumping. All right. How good are you guys with your blood types? Actually, I don't think do you think it mattered to know? I mean, I'm sure it's like, yeah,
Okay.
there you go. That should help. Essentially, just think of it like, you know, you have your red blood cell has like little markers. There's either marker A or there's marker B. Well, that's just kind of both at once, right?
Okay.
So you either have a marker A, you have a marker B, or you have them both at once. Um, if you have marker A, it's okay with anything that has an A in it, or any A markers, but it hates B markers. It can't stand the B markers. It attacks the B markers. And then likewise, the B, it's cool with anything that has a B. Well, it's cool with all the Bs, but it does not like the As. If there's an A, it detects the A, it's going to attack it. So that way, if you have A type blood, you can get blood type A, or you can get blood type O because O doesn't have a marker. Back to B, B has marker B, so it's okay with getting more blood that has B markers, but it does not like A. It can get O because O doesn't have a marker. Um, and then also you have AB, so that means that your red blood cell has both marker A and marker B. Because it has both your blood type A and blood type B do not like type AB blood because it still includes the opposite one in there. And then when you have type AB, your blood is actually okay with either type A or type B because it has both markers. So it recognizes it as one of as one of it. And then blood type O can be given to anyone, but it can only receive O because he hates everything. He can only take itself. He doesn't accept anyone else. And this thing kind of explains it again. So antigen is like what's on the cell. So A has A, B has B, AB has AB, O has none. And A will attack B, B will attack A. AB will not attack anything because it's basically like a mix. So it's cool with everything. And O will attack both A and B. And then the donor part here is which ones it can accept. So A can accept A or O, B can accept B or O, AB can take any of them, and then O can only get O. You might have like a Kaplan question or something for it, but I don't think like the other stuff is really that emphasized. Eh, I mean, eh, maybe like a easy question. I mean, it most it'd just be like, which one can this guy get? There's also RH factor. It's basically an additional marker, and it kind of works with the same principle. If you have the marker, then you're okay with other RH positive, and you're also okay with RH negative, similar to how an A is okay with A or the O. But if you're RH negative, that means you hate RH positive. So it gets more complicated, but it's also, again, the RH factor one I don't think is as emphasized. You guys learned a little bit more about this in L&D because yeah, I'll include the information here, but again, I don't think it's really that crazy. Yeah, it's probably way too much. Yeah. Yeah. And then if you guys recall from L&D, if the similar idea. If someone's RH negative and they get blood transfusion with someone that's RH positive, or if it's like a pregnant woman with a baby that has the RH positive baby, then they will develop antibodies, but on that first exposure, they will not have a reaction because they're only just then creating antibodies. But once they do have the antibodies, it stays with them, and from there on out, they will have a reaction. I just highlighted what I thought was the most important part about it. If it's still confusing, maybe like watching another video explaining it might help. Maybe watching like a visual. Um, yeah, registered nurse RN has a good one. So blood types, RBCs. See if that one's kind of mid. Maybe this one's pretty good. You see here, type A has spikes, type B has circles, type O has nothing. Type AB has both. So if it sees spikes, it's cool with that. If it sees circles, it's cool with that. But if type A sees the circles, he gets mad. If type B sees the spikes, he gets mad. Yeah. Huh. Apparently type O is pretty common. O plus is pretty common in Australia apparently. I thought it I thought it was rare too. Apparently AB's the rarest. Maybe it's just the Australians. I don't know. Oh, you got a ring pop? Wow. No, it's okay. Thank you. Yeah. Um, so let's talk about when blood can be given. What measurement do they use to look at that or determine that? Yeah. So it's able to be given if the hemoglobin is less than 9. But keep in mind, most people will only really give it if it's under 7. So most doctors will not give blood unless it's under 7, typically. Depends on policy, but typically this is what you'll most commonly see. Mhm. I don't know if they heard you. Yeah, Kaylin says you can't catch her donating blood because she's afraid of needles. And then what do we expect to see? So this is something you will need to know. So let's say someone gets a unit of packed red blood cells. What is the expected change in the hemoglobin? So yeah, it's actually by 1, but Kayla, the times 3 is actually for the hematocrit. Yeah, yes. So an increase of 1 hemoglobin, which is typically associated as 3 times the hematocrit. So what does that mean? So if you have a hemoglobin of 7, you can expect your hematocrit to be approximately 21%. If you get a unit of packed red blood cells, you should expect that to go to 8 and your hematocrit to be approximately 24. And it's not exactly accurate, but it gets the general idea is there. It's a good estimation of it. Um, apparently. So when is it appropriate to give blood? We set the criteria, but what are some things that might make, yeah, why would you want to? What are some signs and symptoms? Um, what are some signs and symptoms that will make someone want to get RBC, sorry, to get a CBC to look at yeah, anemia. And what does anemia usually come with? Bleeding, sure, yeah, bleeding, anemia. Anemia usually comes with kind of like what symptoms? Sure, let's go with pallor. Yeah, pale skin, pallor, cool and clammy. Yeah, fatigue is a huge one. Shortness of breath could be. Chest pain could be. O2 could be as well, lower. Um, Tachycardia because of compensation, possible. Basically a lot of your signs of like early hypovolemic shock. Could be low BP, thready pulse. We mentioned headache. Yeah, headache because not enough O2 to brain. Chest pain because not enough O2 to the heart. I don't know why I put lungs to the heart. Yeah, that's pretty much it. Long cap refill. Yeah, like, all the stuff that kind of goes with perfusion. So a lot of your perfusion stuff, maybe cool clamming. And then when it comes to your BP, do you guys remember when it comes to shock? Um, is there anything specific you guys can remember about your systolic and your diastolic? Map is great. Yeah, we love that. Yeah. So yeah, it's like a narrowing, they call it a narrowing pulse pressure. Yeah. So essentially that means systolic going down or staying the same, diastolic going up. So the idea, if you guys remember, like we talked about this when we were in 220, the concept is your systolic, that's the pressure as your heart is pushing it out, squeezing it out, getting it all across the body. So that's going to be a pressure that your body is going to want to maintain at a normal level because that's how it gets blood across the whole system. Your diastolic is the pressure as your heart is at rest. So what you will see, and the reason why the diastolic is up, diastolic is essentially like your systemic resistance. It's how much pressure is just there. It's how much you're shunting, not shunting, it's how much you're clamping down. So, for example, your diastolic going up is essentially your body clamping down and kind of applying more pressure onto the vessels to try to get a better squeeze, better kind of flow of blood through your system. So your diastolic going up is a sign that your body's clamping down. And it's doing that to compensate. And so your systolic is staying the same because it's being compensated. Does that make sense? So systolic is where is your body sending the blood out to the system. And so it wants to maintain that as well as it can. Your diastolic is your resting pressure. It's going up because your body's trying to compensate by having more squeeze, more constriction. Make sense? Yes, no? Yeah. So the concept of that would be, let's say someone has a perfect 120 over 80 as they're starting to have like the start of hypovolemic shock. It's possible that you'll see maybe like let's say like 120 over 85 and then later it's like maybe like 119 over 87 and then oops, you'll see maybe like 117 over 92. That's kind of what you'll see early on. And then when you start getting into that like real shock, like shocky shock, that's because your body is basically failing to compensate. Because it's failing to compensate, now both numbers are going down. The body's not doing a good job. It's not able to keep up, and now you're seeing the like the typical like shocks, the shock ones, like something like this. Now you're seeing this because your body's not no longer able to compensate. It's a similar idea to kind of how I was going down, kind of going back up here to this thing right here where you have initial hypertension and then going to hypotension. So hypertension was the compensation, trying to like trying to make it work, trying to make it work. And then as we're failing, our reserves are failing, so your blood pressure goes down. You might also see if someone's having like respiratory failure, they'll be hyperventilating, right? And then as their body's just giving up, that respiratory rate will stop being high and start being low because they're done. Their body's done. So your body will always try to compensate. And when it reaches these numbers, it's because it's already starting to fail the compensation process. That's that's difficult to say, honestly. Um, yeah, it depends what's going on.
Like severe MVA and they are just bleeding out of everywhere they can, then it's gonna drop out pretty quick. They don't even have a chance to try to compensate versus Yeah, it's very situational. Like, I'm trying to see what else. Anemia was another one that was mentioned. So, like, for example, like, there's a lot of there's a lot of girls that some of our girly pops have anemia because it be like that sometimes. But their like blood pressure still maintains moderately okay. Mine's low, but um, that's a completely different story and completely different like values that you're gonna see as compared to someone like really really crashing in front of you.
Yeah. Also, keep in mind, and you'll go over this a bit more, I think, next semester, that blood pressure, because we mentioned that it's always compensating, um, might not be the best indicator for perfusion, um, as opposed to your pulse. So weak, thready pulse, quick, fast, thready pulse. The change in, if you guys actually recall from 220, your first indicator of shock is actually your change in pulse rather than your blood pressure. Because again, your blood pressure is always being compensated on. You might not see, exactly, yes, you might not see those changes in the blood pressure until later when stuff is really going down. But it's the change in your pulse quality. Maybe the respirations are getting a little bit higher. Maybe the urine output is decreased because your RAS system is activating and your kidneys are trying to keep all the fluid in to try to, again, compensate. So, and you'll go over more about this later with Mr. Robbins. But yeah, that's kind of the general idea. So just a good review on perfusion. Um, Who else is it appropriate for? We can say here anyone with, we said bleeding, so let's include trauma, maybe chronic kidney disease people because they're naturally like anemic. But it's worth noting that they will normally get epogen first. Sickle cell as well, yes. And I'll just give this here. Yeah, chronic kidney disease. Boom. Yeah, if you recall, they don't make erythropoietin, which is something that the kidney makes that helps to stimulate the bone marrow to produce RBCs. And then they can get synthetic erythropoietin known as epogen. I think he might have told you guys to know what this is. So here I just kind of wrote probably the most important stuff about it. All right. And then we'll kind of move on from there. All right. So this is going to be essentially like a bit of a review of how blood infusion, the skill kind of goes. So when it comes to like safe administration of blood infusion, what are some things that you have to do in order to ensure that we're not going to cause a reaction, or may not always going to ensure it, but like to minimize the risk of reaction? Compatibility. Okay. So let's talk about compatibility. We can do that with a type in, yeah. So there's a type in screen and then there's a type in cross. So do you guys know the difference between type and screen and type and cross? Right. So I would say with screening, type and screen is you're basically checking to see that the blood type is compatible with the, basically type and screen is just kind of like getting your blood type. And type and cross is like specifically taking the donor blood that was already being considered and actually like directly testing it with the donor's blood. All right, cool. But I think that's the difference. So like,
Them, like one of them, one of them is just like in preparation for someone you think might need it, so that you can pull the
mhm,
units on hand. And then the other is like, oh, it's going down. We gotta do it now.
mhm.
That's what I know about it. You don't have to know that.
Yeah, you don't have to know that, but if they do get one of these, they'll have a blood 2 units for type and cross on reserve. Yeah, like a band that has their number.
Oh,
Yeah,
okay. I didn't understand that. I thought you.
right.
I didn't equate it to like the first thing.
Oh yeah. Oh, with them. Anything else? Something obvious? Obviously, you have an order for it. Um, what else can you guys think about? Vital signs? Okay, yeah, I like having vital signs before. Pre-medicate? Sure. When would we pre-medicate? Pre-medicate with what? I like that. Too large bore. My V's. Tylenol, Benadryl, if appropriate. Yep. Yeah. History of reactions. What else? Allergies.
I understand what they're trying to get to.
What are they trying to, oh, what do you mean?
I'm assuming that's not what they mean. That one. I'm assuming that's
Oh,
what they mean.
like you mean like allergic reaction? Like a reaction in the past? I think that's kind of like a straight up blood reactions. Have Yes, so have an extra unit. Have NS. Have a like a 1 liter bag of NS primed in case of emergency.
In addition to the one that
Yeah,
you
in addition, yes. Yes.
technically you have two.
Yep.
Consent,
Yep.
verify, love it, please.
Yes, informed consent. And also like even like informed consent, so like the signed paperwork and verbal consent. Because you got consent that they can do a blood draw, and then you need consent that they are doing it now. Verify with blood bank another nurse. Yeah, so you are going to be reading it off with another nurse. So second RN check. And basically that's where you're looking at the unit and you're kind of confirming it through like closed loop communication with the blood armband. Okay. And the paper. And what else can we talk about here? Yes. Yes. So slow administration initially. So probably for like the first 15 minutes or so. Probably 15 minutes of approximately like half the rate. Yeah. And then kind of go a bit faster. I think what I have here is I have 60 mLs per hour for the first 15 and then increase to about 150. Count,
Dude, you know,
counted vital signs 7 times. Yeah, there's a lot of vital signs for that. We'll kind of talk about it because there's like you have your vital signs about a few minutes before, like I think it's like 5 minutes before. What else included? Yes, so yes, it does need to be. We'll kind of put that in here. During infusion must be infused within 4 hours. What about, we kind of already talked about, so before administration, how much, how many units of packed red blood cells can each tubing set be used with? So it's actually, Jennifer, I'm gonna need you to erase this. Take that question mark off, Queen. There you go.
bro,
Hold
you've been trying to copy this thing for months.
on. So each tubing set can be used with up to 2 units of, huh? Yeah, of course you did. Each tubing set can be used with up to 2 units. What does that mean? It means you have your Y set, 1 unit of plaque red blood cells. The other side is normal saline. You go through the one unit, then you unspike, spike with another unit, and then you go again. And you flush with that normal. That's the reason why that normal saline is on the other side of the Y set is to flush in between each unit because you will run out of the bag and then still have blood in the tube, but you don't want to put air to get the blood in there. So the NS is there to flush the rest of the blood through the line and into the person. And then from that point on, you can unspike, spike the new blood, and each tube Y set is able to you're able to do 2 units on it. Mm. I mean, it's if it's type and cross, then it should be fine. So like, in theory, it should work just fine. Yeah, it's open screened. Yeah, yeah,
Then how long after you pick up the blood does it have to be?
yeah. So she wants to know how long after the blood has been transported do you need to start? Yes. So yes, 30 minutes. Screen. So this is my understanding of type and screen versus type and cross. My understanding is type and screen is getting the blood type and kind of having that on file, while type and cross is like directly, like they literally took the blood of the patient and the blood of the donor that they're thinking about using, and they literally like tested them combining with each other and seeing if there's some sort of like lysing or reaction. I think so. Maybe I just made all of that up. Let me look it up.
I was gonna
Let me
say
double check.
like then I think if they choose the use that makes sense.
Hmm.
Oh, yeah.
Yeah. So yeah, it is cross matching. So let me ban screen. This is time ban cross. Okay, here's the information. Again, this is extra. You don't get tested on this, so don't even stress. Don't trip. Yeah. There you go. Oop, that didn't come out nice. Oop, that still didn't come out nice. All right, there we go. That's fine. It's fine. So type and screen is like I said, you get the blood type, the RH factor. Wait, what? Oh, okay, bet. You literally don't need to know it. I'll post it in the chat if you're interested. But basically, yes, type and screen is getting the blood type RH, and I guess they screen for random stuff in the blood that could cause reactions. And then type and cross is they literally grab your blood, they grab the donor's blood that they're thinking of using, and then they put it in like a little thingy-mabobber and see if there's a reaction. Um, okay, let me see if there's anything we haven't talked about. Yeah, we talked about getting it in 30 minutes, starting it within 4 hours. Um, all right. Let's talk about temperature change, please. Yeah, we'll talk about that during the like when we go to overreactions. I know there's a lot of stuff that kind of goes with this, but probably the only other thing is if the patient has CKD and CHF. So if patient has CHF or chronic kidney disease, what are we kind of thinking about? They're getting blood. Oh, there's 2 things. Okay. Yes. Yes. Fluid volume overload and anything you can consider doing or like, you know, prior. Yeah. Sure. Sure. Like Lasix, yes. So you give Lasix. You can also consider slower infusion. So maybe you actually do it in those 4 hours. Like you try to get it actually done within 4 hours as opposed to being like, well, this person doesn't have CHF. We can finish the blood in 2 hours. Um, right? So slower infusion, maybe take up the whole 4 hours. How slow? That would be however how yeah, that's your well, that's based on so one so like a unit of blood is not a consistent amount of mLs because a unit of blood is specific to the patient based on their weight, their height, I guess sex, etc. So a unit of blood for me is probably different than a unit of blood for Kaylin, different for a unit of blood for someone else. Um, so however mLs are in that unit of blood, you would, I guess, take those and then divide it by 4 hours if I wanted to take the whole 4 hours, and then that's how fast you would do. So let's say in theory that a unit of blood for me is like 300 mLs of blood, and I have chronic kidney disease and heart failure, then I would do those 300 over 4 hours. So 300 divided by four, and it means you would run it at 75 mLs per hour at the speed of that. Make sense? Yes, no, maybe. And if you're doing that like initial slow phase, then you should also kind of take that into account. Um, yeah, so like take that into account for how fast you need to do it if you're going slow initially and then going faster after. But for the most part, that's pretty. Oh, and actually, there's one more thing. Sorry. The last thing is you want to get a urine specimen prior. What is the purpose of this urine specimen? So, elaborate, Jennifer. Okay. Urea. So, what's the purpose? So, it seems to be. I'll give five more. I'll give a few more seconds. Otherwise, it might be like a slight muddy point we can clarify. Yeah. So that initial urine specimen, if the patient has their blood transfusion and nothing happens, then I believe it's just thrown away. You don't really use it. You don't need it. Yeah. Yeah. So if nothing happens to that patient during their blood transfusion, that blood specimen is discarded. There's no use for it. Um, if they do have a blood transfusion reaction, then what they do is they get another urine specimen after the reaction happens, and then they compare the one you got before with the one you got after, and they're looking for blood in the urine. Um, so if you have no blood in the urine on the one you got before the blood transfusion, but there is blood in the urine on that second one, it's showing that they had a hemolytic reaction. So their reaction to the blood caused the blood to burst, and now they're bleeding from all the blood is just bleeding out, and they're peeing it out. So I'll kind of specify. Does this make sense? Yeah. And the idea would be if you have hematuria in the second and not in the first, hemolytic reaction. If you have hematuria in the first, but not or in the first and also the second, it might have been just a thing that was already occurring prior. And then it might have been a different type of reaction. This is for all patients, yes. So hint, hint, if you're in sim lab, you will need to get a urine cup sample before. Regardless of what happens in the scenario, you're gonna get one before. And if something happens, you're getting another one after. Does this make sense or more clarification? I think it might just be like a standing like order kind of thing, right? The prior urine specimen's like a standing order kind of thing, or just no, it's just something you do. Hmm. Okay. Right. Yeah, okay. So I guess she's actually experienced it. So basically there's no direct order for it, it's just something you do. And if there's a reaction, you get a second urine specimen and then you call the doctor and be like, "Hey, they had a reaction. I have two specimen. I got one before, one after. Can we get an order to have lab analyze it?" Something like that. So Jennifer asks if there's blood in the first urine sample, we still move forward with blood transfusion regardless. If there's blood in their urine, there's something else. Like in the first sample, like before you even start the blood transfusion, then it's something else. It's not a blood transfusion reaction. So yes, you would still do the blood transfusion because if there's blood in the first sample, before you even did the transfusion, then it's not a reaction. It's due to something else. So I'll add that too. If hematuria, and to be fair, if there was hematuria in the um, because sometimes it's like it's like you can't really see it. Sometimes it's very obvious. So, unless it's visibly obvious on that first one, then you would never know because you're not sending the first one to the lab unless they have a reaction. Does that make sense? So if there's no reaction, you're never doing anything with it. Unless if it's visibly bloody in the urine, then you still give the transfusion, but now you know that they have hematuria, which could be due to other stuff. Maybe they have like a kidney stone or something. If that makes sense. So it wouldn't impede the transfusion. And if it's like a hidden hematuria, like it's microscopic blood in there, and you can't see it visually, you'll never know from the urine sample because you're not using the first one. We're not sending it over unless they have a reaction. I know it's kind of confusing, but the general idea is if you're doing blood transfusion, you get P sample. That P sample, set it aside. If they have a reaction to the blood, then you get a second P cup. Make sure you differentiate between the two. Call the doctor about it and do whatever intervention you need to do with the patient to get an order to send them both out, and then they will compare them. If no reaction happened, that P sample just gets thrown away. All right, cool. This may or may not directly help you with your simulation lab. So we talked a lot about this already, so I will just kind of copy paste this for the during infusion right here. Also, number 5 on competency for CPE. Wait, what's that? blood admin. Number five competencies. I don't know what you mean by that. There's no there's no blood admin for your CP. You don't have to worry about that. Yeah, don't trip about it. It's just sim, allegedly. No, there's no blood admin during CPE. Assuming nothing's changed, but I don't know why they would, because they're literally about to change the whole curriculum after you guys. So like, I can't imagine they're gonna do extra work for no reason. Yeah. Oh, there's another one in the refrigerator. I think maybe. Oh, all right. Just leave it outside and I'll... Okay. So here again, it's stuff that we already kind of talked about. You're staying with the patient their initial infusion. Um, and we talked about the half rate for the first little bit, vital signs. So vital signs 5 minutes before infusion to get a baseline during infusion. Um, like pretty much minute zero, get one. Then 15 minutes later, get one. Then every hour, get one, etc. Right? Every hour two, etc. So what else? So we talked about like CHF and CKD patients. So what, and we mentioned like eyes and nose and we mentioned weight. So what is inappropriate weight gain? Yeah, inappropriate. Yeah, so 2 pounds in a day and 5 pounds in a week, exactly. And what do you do in this scenario? What do you do? What can you do? Yeah, do yeah, it's basically yes. But you would call the doctor because changing condition plus you need an order for the Lasix if they don't already have it. So pretty much yes. So assess, call MD, probably give Lasix. And we already talked about all the patients at risk and some other stuff here after infusion. We kind of just go here. Assessment of patient after infusion. You're looking for decreased signs of anemia, which we talked about up above. And we talked about how 1 unit of RBCs means one hemoglobin up. And then your hematocrit should be 3 times your hemoglobin. Okay. Okay. Questions, concerns? Yeah, there is a lot of info, huh? Even me shortening it, it's still a lot of info. I think blood is probably the lengthiest, huh? Everything else is not too bad. Nope. What new skills would be in the CPE? Trach. That's it. If you get it. Again, I guess you weren't here for this. I'll give you TPN. No, we don't do TPN ever in anything here. I guess you joined a little bit later. Central line. Central line has its own CPE. That should help. Da, da, da. Yeah, by the way, a little early, but when you guys finish 240, put me in the guest list, I'm trying to be at the pinning. Ba, ba, ba. Oh man, that's funny. All right, so now we're gonna go over blood-related reactions. So there's a what? Yeah, there's a lot of stuff here. So what do we got here? What are some things you guys can expect from a blood reaction? Honestly, it's a lot of the stuff we've been talking about. Honestly, yeah, rash can be one. So that's kind of the allergic part of it. Shortness of breath, yes. That could be an allergic reaction, shortness of breath, hematuria. Yeah, we talked about um, hemolytic reactions. Itching, yeah, so itching again if it's an allergic reaction. What else can we expect? Tachy, yeah. Tachycardia and tachypnea. Or compensation. Yeah, headache for sure. So we talk, it's similar to anemia, huh? You're getting a lot of anemia ones. So what else did we say for anemia? Impending doom. Yeah, so that's kind of like a shock thing, right? So a lot of shock symptoms, a lot of, again, stuff that we went over. Yeah, exactly. So we can have hypotension here pretty much happening, especially if you're having like an anaphylactic, like some sort of like reaction like that, where your whole body just, blood pressure just dips out, shortness of breath, um, fatigue, sure, yeah, fatigue. Alongside the headache, we mentioned this before, so chest pain as well. The hematuria, that's the blood in the urine, so yes. And other things I would say was probably fever, potential fibrolytic reaction, and maybe some tingling in the throat. And why do you think the tingling in the throat could be a sign of potentially something that could potentially happen? Closed, yeah. So it's a possible sign of an eventual airway obstruction. So that's not very good. And then what do you want to do? Let's say you start the patient out on blood. 2 minutes later, they're like, hey, my throat is kind of itchy. My head's starting to hurt. They start breathing really hard. It's like, oh, my chest feels like it's pounding. Oh, dude, I'm scared. Yeah. Stop the infusion, of course. What? Yes. So yeah, you're gonna stop infusion 100%. You're gonna, of course, focus on your ABCs. That goes without saying. So you guys know all about that. Yeah, like O2, call a rapid. I like that. Call a rapid response team. Get them in there. We mentioned the bolus. So I think I remember this was like a contentious thing with our class because we were told like different things by different instructors. So it was a little confusing. But what I believe makes sense is for us to stop the infusion, DC the tubing, and then connect that same IV with a separate bag with the separate bag. Remember, you had two lines with the that you prepared before. Separate bag of NS and then give a bolus. So remember, you have the Y set, you have the blood connected to that normal saline. But if we were to stop infusion and then run that normal saline that's in the Y administration, then you're pushing whatever blood is still in the tube through them, which is what we don't want because that's what's causing the reaction. So instead, we're going to disconnect the blood tubing, let me specify that, and then connect that IV to the tubing of the normal saline that we prepped earlier prior. And that's what we're going to bolus them with. So why are we bolusing? We mentioned that they're probably going to be kind of very similar to like a shock thing happening here. So that's why we're bolusing them. Um, yeah, and then the idea behind this is that they're getting that NS bolus in that first IV, and now you still have that second IV for you to use for medication while they're getting fluid resuscitated. You have that second IV for maybe a different bag of RBCs that might actually help. A vasopressor maybe, yeah, maybe they're getting maybe the bolus isn't helping. Maybe we need to if they're having an allergic reaction, maybe they need some epinephrine. Maybe they need vasopressors. Stuff like that. So that's kind of why you have that's the application of that second IV coming into play. So again, if they have a reaction, you're stopping the infusion. You're going to disconnect the blood tubing. At the same time, and you're going to be doing a lot of things at the same time. You're going to call a rapid right away. If they're having struggles breathing, you're going to have get people to come over, get the O2 on them, disconnect the blood tubing, get that NS bag that you prepped separately, connect it in. It's already should already be primed, and then bolus them, and then you still have that second IV for whatever else you need. Column D, blah blah blah. Some other things that we kind of talked about that I think, makes sense. Um, Vital signs every 5 minutes. So that's where you would get you would have basically like the whole team there, maybe have like another nurse do it so that they can interpret it, or have your CNA get the vital signs while you're in the room. So they'll tell you the vital signs, and as the nurse, you interpret it. And then some other things you can do is here. So notify the blood bank, blah, blah, blah. That's like, hey, we're going to send this back. The second urine sample, like we talked about, and then documentation. You stuff is going down, so as always, you're gonna document what happened, and you're always gonna document what you did. You don't want to just have documentation where you're saying everything went to shit and I didn't do anything. No, you're always gonna say things went to shit and then I did something. Stuff like that. It's just general like documentation tips. Okay, makes sense. I know it's a lot, and it is a lot. But again, this is just getting you that. I think this is gonna help you really prep you for your alleged simulation where you allegedly have to do this. I think for testing purposes, there's gonna be some things. It's gonna be a lot of focus in on recognizing reactions and understanding what the interventions are. I think there may or may not be a question about like how much we expect it to increase, maybe, perhaps. Probably expect this to be something that comes up, like what's an inappropriate weight gain, um, stuff like that. There might be some stuff about logistics, like some of the logistics here, but the focus is always going to be on signs and symptoms and interventions. Okay. And we've been talking about all these reactions. So we talked about hemolytic reaction. We talked about febrile reaction. We talked about kind of like anaphylactic shock. So anaphylaxis. There we go. FBO. I think they have like there's like a specific, it's like a taco, and there's the other one. I can't remember the other one. Transfusion, this transfusion associated circulatory overload. And I can't remember what the other one is. I think it's part of your sim packet. Let's see. TRALI, transfusion related acute lung injury. So that's something you'll have to look up for your sim. Like they tell you it's part of like the pre-assignment, like the pre-homework. But you don't have to know it for this. Just I just remember taco because it's funny. And there's so much information here. I am just going to just copy paste everything and just talk about it because there's so much information here. For the most part, you just kind of have to know the basics. So hemolytic, why is it, what's a hemolytic reaction? It's because the blood was not properly matched. Um, Maybe it wasn't properly crossed, or something else happened. Um, if you have a hemolytic reaction, you're literally having your own red blood cells pop each other, burst and stuff. So that's not good. That could lead to these things right here: DIC, renal failure, death. And I would say the key things to really think about, and actually I guess it's something I didn't include in here, is the flank pain. You can have flank pain, which is indicative of your kidneys kind of hurting, you know? So I would definitely keep note of these in that are bolded, and I'm going to highlight them as well. The back pain is a big one. Chest pain, hematuria. And again, similar to shock. Another thing I guess that can come up is kind of like with your burns or rhabdomyolysis, you have bursting of cells. And anytime you have bursting of cells, you're thinking about potassium because potassium is in the cells. So if it bursts, then you're releasing potassium outside into the main bloodstream. Similar to how when someone gets a blood draw, you might have it's possible for their potassium level to say like 9. And that doesn't mean that it might not actually be 9. It might be that the blood hemolyzed, meaning that either the technique was wrong or something went wrong with that with the getting the blood draw that caused some of those red blood cells to burst and the potassium levels when they did the blood draw comes off wrong. So that's something I actually had a patient that had like potassium of like 14, but what happened was that they had improper technique on the blood draw and they hemolyzed the blood. So the potassium was not correct because of that. But that's kind of the same concept. Anaphylaxis, main thing I would remember is the signs and symptoms, of course. So always signs and symptoms and maybe some of the stuff that you do. So Benadryl for pre-medication, epinephrine, which makes sense with like other like someone gets a bee sting and they're like deadly allergic to bees, then you get epinephrine to the thigh. Because this is something that's going to um, kind of essentially counteract some of the effects of the anaphylaxis, where your blood pressure drops, your airway closes. The epinephrine's going to do the exact opposite, so it's going to make the blood pressure and heart rate go back up. It's going to make the lungs open up again. So I would say these are the main things, including the signs and symptoms, of course. Fluid volume overload, we did talk about that. So we'll probably, this is actually called a taco. Um, yeah, this is important. Remember, the Lasix is something you can do. So I think this is an important thing to keep in mind for the test. And it's also worth keeping in mind to consider the elderly as well, not just even if it's elderly with no CHF and no chronic kidney disease, because as people get older, their organs function worse. So they need a slower transfusion rate. They need because they're at a higher risk for FBO, even if they don't have CKD or CHF necessarily, just because of their age. They are more at risk of FBO. And with FBO, I know you guys know this right here, which is important. We know about crackles in the lungs. We know about the blood pressure change. We know about the pulses and JBD and stuff. And then last thing is just like bacteria. There's the blood that was giving us contaminated, and we gave them bacteria in the blood directly. But that's why it's important to start that you finish transfusion as quickly as as quickly as you're allowed to. So within those 4 hours. Any questions on blood? Because I know that was a lot. That 100% was a lot. All right. So we are going to move on to FFP, and this should be considerably faster. So what um what is FFP used for? What does it affect? Clotting factors, exactly. So what do those include? what are the clotting factors? So we have PT, we have INR, we have PTT. Oops. And I don't know if you guys remember your exact ranges, so I'll just kind of write it down. This is from 212. And Khaled said not platelets. Yes, exactly. So if you need platelets, you get platelet infusion as opposed to FFPs, which is the clotting factors. And I think I get asked like, what's the difference, right? Do you, so the difference between like the clotting factors and the platelets, it's essentially like the clotting factors helps you create clots, right? It's gonna help create those blood clots. The platelets are going to be other cells that kind of come in. They're kind of like your body's um like first like one of the first responders for like an injury that come in to try to kind of patch things up, but it's not quite the same. So the way I think is a little bit better for describing it is how you have heparin. You have heparin that we give for DVT. And that helps to prevent blood clotting in the legs because you have thicker blood. Essentially, um, you have maybe dehydration, they're not moving around, so stuff can pool over. And if your clotting factors are high enough, it can cause them to kind of stick together and create a clot because they're clotting together, they're coagulating together, right? So that's why you'll hear like coagulating slash clotting factors. But for something like preventing a stroke or preventing an MI, people instead take medications like aspirin or Plavix, which are antiplatelet medications, because a lot of the time, um, the clots that happen there are more due to platelet aggregation as opposed to just like a little blood clot. So maybe you'll have a little blood clot that causes an insult, and then your platelets go crazy and make things worse. They think they're trying to help, but they end up making things worse and causing even more occlusion. So that's kind of the difference. They're both are going to be used to patch up bleeding and stuff, but I would say when it comes to clotting factors, that is going to be most effective for preventing venous clots. So that would be like a DVT, for example. Okay. Um, Additionally, uh, you also have like kind of like platelets. You said here, obviously, yes, it's most. Sorry, I think I just kind of said the opposite. Sorry. This is for like anticoagulants. Let me rephrase this because I got let me let me let me let me include that as in a separate line so we don't get confused. Just so that you guys kind of get the idea what's the difference. Um, Hence why you get anticoagulants. Platelets are most responsible for arterial clots. So what is that? MI, stroke. Hence why people get aspirin, Plavix for those. Okay. So there is again, it's very extra information, but if you've ever wondered why you can have one but not the other, or why someone might be on Plavix for like risk of stroke, but still want the heparin, it's because the heparin's going to be better to prevent the DVT while they're immobile in the bed, while the Plavix is keeping them from having another stroke or MI. And they have different actions, hence why taking them together is not doubling up on your same exact med. Even though they will both increase the risk of bleeding, they do have different actions. And then even then, you guys recall for stroke they have like dual antiplatelet therapy, so they'll get aspirin and Plavix. But that's neither here or there. It's just kind of adding more context. This is just for context. Don't worry too much about it. But that's kind of why they're different and why you might use them for different things or why um, you can have someone with normal platelets but bad clotting factors due to certain diseases. Um, okay, so considerations. Just because I don't want to take too long, I'll just kind of specify when it comes to fresh frozen plasma, you need to have compatibility between blood types. So someone that is donating plasma, you need to still have that blood type compatibility. Okay. And I will just add some other stuff here. Just again, a quick list of patients that could be used that could get FFPs, bleeding, trauma, too much Coumadin. Because remember your Coumadin slash warfarin, that is your anticoagulant as well. It messes with your clotting factors. And yeah, someone with DIC can get fresh frozen plasma because they're used up all their clotting factors. Remember, that is one of the definitions of DIC is the use up all your clotting factors. And this one's just kind of like a little extra. Um, because your packed red blood cells is literally just red blood cells. It doesn't come with the plasma. So if you get a whole bunch of red blood cells, it might dilute your clotting factors, and that's why they might need more plasma, if that makes sense, because you diluted it. And then what are you monitoring after infusion? You're gonna want these values to fall down more normal. So um, yeah, so you'll have a decreased PT slash INR because remember this is your PT and your INR and your PTTs rather are based on seconds, so that's how long it takes to clot. So if you have more clotting factors, these numbers get lower. Okay, looking for less bleeding, less bruising, and you are getting a bolus of something. So same idea. If you're getting a large bolus of something, look out for overload. Vending machine. Cool. Yeah. So then for platelet infusion, wait, more luting factor, the HR increase. Other way around. Remember, your warfarin is an anticoagulant, so anticoagulant makes the INR go up, which is why the normal warfarin INR is 2 to 3 because they're already on anticoagulants. But it's normal for it to be higher because they're on anticoagulants. So this is their normal. Does that make sense? Yeah. So again, their whole. I'm not sure, honestly. I'm not sure. I think they usually separate them because not everybody that's getting um. So instead of having like a separate like okay, we got blood type O, but this one's a whole blood transfusion. This one's I'm sure there is, but like I feel like it probably makes more sense to separate them because you get more use of it. Because not everybody that's getting blood needs the plasma and the platelets. Not everyone that's get needs the plasma and the platelets needs the blood. But maybe I'm not actually sure. That's a good question, I think. Yeah. All right, all right. With platelet infusion, why are you getting platelet infusion? Because your platelets are low. That's pretty much it. Platelets are low. Your normal range is this much, but typically you're more likely to kind of receive it based on these factors. If you guys recall, usually they don't start caring as much about the platelets, even if they're below normal, until it gets to under 100. I think key factor is that ABO compatibility is not needed. And then here's some qualifying factors. So less than 50 with symptoms, you're gonna get it. Less than 20,000 with even if you don't have symptoms, you're gonna get it. If you're actively bleeding, you're gonna get it. If they're going into surgery and they're under 100, you're gonna get it. I think the main thing with these two is just make sure you don't confuse the fact that fresh frozen plasma is not going to affect platelets. So that's going to be like a quote unquote trick question you'll get. And I know they also in the lecture talked about like how fast you're running it and like they have filters and stuff, but that's just for context and you don't have to memorize it. Okay. Any questions? Otherwise, we'll go into TPN, which should hopefully again also be pretty fast and we'll hopefully try to end by like 8:15 or so. And I know we do still have like leukemia and stuff, but I'll probably do that a different day. Ba, ba, ba. Yes, so kind of like vice versa. So fresh frozen plasma is going to affect the coagulation factors only. It's not going to affect platelet count. And then platelets are going to affect platelets only. They're not going to affect the coagulation factor count. So fresh frozen plasma only affects PT, INR, and PTT, while platelets are only going to affect platelets. All right, so we're almost done. I know it's been long, but yeah, this is a really long amount of content. Luckily though, week 2 is very light. So what I'm thinking of doing is I will do your hematology actually when alongside your week 2 because your week 2 is leadership, and we'll just go over the absolute like most important stuff about it. So we'll go over this then. But getting this out of the way first, I think is great just because one, I actually, if memory serves me correct, the focus on the first exam was more on this concept than the hematology as much. And also, even though like the leadership content is pretty easy, there were a lot of prioritization and delegation questions, and that's where the test is kind of consisting of. It's mostly consisting of these three topics plus delegation, prioritization, and then a little bit of hematology, if memory serves me correctly. So that's what I'll do. I'll give you guys this leukemia, lymphoma stuff alongside your leadership next week. But for now, there's a lot of content, so you can take it all in. Liver for the midterm. That should be right. Can I actually see? Can I see? Actually, maybe I could just log on. I'm curious about CLTP and hematology, hepatic, and leadership. Oh, okay. Sure. I guess that's how it was. Yeah, I don't think hematology was very very high content like amount. Okay, then yeah. I definitely I already have liver stuff ready for you guys. But we get there when we get there. Yeah. Okay. So now TPN. Main thing need to know is that it's through a central line. When to use it, slash who is it for? What are some examples you guys can think of? Basically, yeah, if your entero route is not working. So GI issues, if somebody is having a stroke and they're having a hard time eating because, they're a risk for dysphagia, I think you'd be far more likely to actually get an NG tube or a J tube than to get a TPN, because TPN is directly basically feeding essentially through your like getting all this nutrition through your IV. And I mean, I guess, yeah, you said 7 to 10 days. So that'd be like when you're MPO for a long time. So maybe like 7 to 10 days. Although they try to avoid it, it is expensive. Plus, there's a reason for why you would not want to do TPN over like an NG tube. Um, yeah, like infection risk. It's essentially, your GI tract, that's a muscle. That's a bunch of muscle. So it still kind of follows that same principle of use it or lose it. And if you're not using it, then you have your bowels are slower. Bowel obstruction can occur, infection, translocation, and stuff like that can occur. So if you're able to, you want to use the GI tract if possible. Yeah, there's a lot of reasons, but yeah, yeah. So you guys kind of have a lot of good examples for that. Someone that needs to rest their bowels and still needs nutrition. So someone with like maybe like severe case of like severe exacerbation of ulcerative colitis or Crohn's disease that is gonna be MPO for a very long time, they might give TPN. Here's kind of what I got. So GI tract is preferred if possible. If you have TPN, you are by default needing a central line, so you're still thinking about CLABSI. And there's also bacterial translocation, like you mentioned, like infection. So essentially, just because you're not eating enough, you can have overgrow of the bacteria that's naturally in your gut, and that can allow for them to kind of like an opportunistic infection. So they can get flagell for prevention. I would say that's as much as you need to know about the specifics of that. Now, there was a very long part of the lecture that was like breaking down everything in the TPN, and you don't need to know that at all. I think, well, let me specify. You don't need to know like hyper specifics, but you just want to know the general idea of why these are in it. So why do you need protein? Like what's protein there for? Okay, what about muscle? It's prevent muscle. What happens if they're not getting protein? hmm You're wasting yeah, you're not able to make enough protein, you become muscle wasting. So the word the phrase that they use is maintaining a positive nitrogen balance. And there's stuff that you can get really nerdy on in terms of that, but all you really need to know is this is that it's there to prevent muscle wasting. And here is cachexia. That is the medical terminology for it. So if you see it in the test and you don't know what it means, now you do. If you were looking for muscle wasting, it might have been written as cachexia. So now if you don't, now you know what that is. Yes. And then your carbohydrates used for energy. And then another thing that's nice about carbs is that your body naturally is going to use carbs as energy. When the body's not getting enough carbs, it will begin to break down muscle and fat for energy. It will actually prioritize protein first for some reason, which is sometimes why losing weight can be kind of hard. Because sometimes you're losing weight really fast and you're actually losing muscle first before you lose some of the fat. Because your body's weird like that. But the reason that and here I kind of wrote down is like no similar to fasting. Yeah, yeah, same idea. Um, yeah, that's also a reason why like bodybuilders avoid cardio because cardio ends up leading to a kind of burning all your carbs, and then your body will actually start to break down protein first. So bodybuilders avoid cardio because it makes them lose gains. Um, but anyways, the only thing I have highlighted for here is that the average, like the typical amount of dextrose in your TPN is about 10%. So just keep that in mind. And the only other extra information I have for that is sometimes for people that are MPO, they might get like D5 half an S. And the reason for that is because that D5, like 1 liter of that a day or whatever they're getting, that D5 is actually is theoretically just enough carbohydrate calories that their body doesn't break down muscle, or at the very least, it slows down muscle wasting. So for someone that is MPO, but they don't qualify for TPN yet because they've only been MPO for a few days, not quite that super lengthy amount of time, and they don't want to put an NG tube, they could be on like D5 half an S or like some sort of dextrose IV solution because those calories help to prevent muscle wasting because you're giving your body some amount of sugar to prevent muscle breakdown. It's about all you need to know. Then for your lipids, I do have some things about that because I know you guys went over your TPN and then you went over your lipids a lot of the time. It's hung separately to your TPN. Um, Main thing would be that your TPN is infused over 24 hours. Your lipids are usually infused over 12. If you're allergic to eggs, you can't receive it because they use some of the egg protein in there. And this is probably all you need to really think about. Your fat embolism is possible, but probably not that as likely as, but it is technically possible. And you have a lot of the same signs and symptoms as you do your, um, with your air embolism and your pulmonary embolism. It's basically the same idea. It's basically fat clot, a clot of fat getting into the lungs. Yeah, at least lecture wise, it was 24 hours for TPN, 12 hours for lipids. So lipids are infused faster. Okay. You also have H2 blockers. So examples of that are famotidine is probably like the most well-known one. That's Pepsid. Is it Pepsid with a C or Pepsid with an S? I think it's Pepsid with a C. Yeah. And I'll just give you an extra one just for fun. Retinidine. What is the purpose of H2 blockers in these patients? Or sometimes maybe you guys have been in clinical and because I know we learned about GERD, but you'll have people with like protonics or famotidine that don't have GERD. Why are they getting it? Yeah, to prevent stomach ulcers. Why might they get stomach ulcers? Stress. Yeah, stress ulcers basically. Empty stomach as well. Yeah, pretty much. Yep. So, yeah, that's a good thing to keep in mind. So like, if you see like protonics on a non-GERD patient and your teacher asks you what it's for, um, it's not for GERD, it's to prevent stress ulcers, right? Because there's multiple uses for meds and stuff. And then it also comes with water, vitamins, minerals, electrolytes, and then, we all know about that. We all know that that's important for us to have. Okay, so hopefully, I mean, there's also, I guess there's this part here. It can sometimes have insulin and heparin in there. What type of insulin is acceptable IV? Yeah, so regular insulin only. Okay, and I'll tell you right now that Mr. Robbins he loves the kind of using that as a trick question where like IV insulin. Like maybe the answer is IV insulin, but like MP, you remember you're only allowed regular, so sometimes they'll put like MPH IV insulin, which is wrong because only regular can be put to the IV. So just letting you know ahead of time. What else is important to know ahead of time? Um, oh yeah, how about I tell you about this as well? When it comes to um, I guess your central line dressing change. Yeah, I'm not surprised. Yeah, he loves that question. Yeah. Another thing he loves, and I know he's said this to you guys, is I'm pretty sure he said straight up said it was a question. He says, there is a difference when you're doing like your central line dressing change for questions, there's a difference between sterile and clean gloves, right? So for our central line dressing change, we are not doing it with clean gloves, we're doing it with sterile gloves, right? So we're not going to put clean. Yeah, so we're not putting clean, we're putting sterile. Or if it's not there, then we don't click. It's just it's not there. But we're not pressing the clean button, right? We got that? Yeah. In general, as you guys will learn with Mr. Robbins, definitely uh his lecture and his voiceover, that's kind of the main thing you focus on. You don't really need to read anything for his content at all, like at all. Like going off his lecture, especially his audio and his slides, that's all you need. And he will drop, usually if he repeats something, there's a reason he repeats something. If he mentions like a random like off tangent thing, it might be relevant. And last thing I'll say is this right here. It's important to know what's in the TPN and monitor labs. So that's pretty much it for concepts. So the goal is we kind of mentioned it here. We mentioned it already. We want weight maintenance. We want to promote healing, positive nitrogen balance. I don't know if it's for this class though, or a different one, but if I recall, um, he also stresses out, at some point he will stress out things like, prevention versus goal, like your goal, like what, like sometimes you'll have like a question that says, what's good to, like, what's your goal? Um, your goal isn't to like give a high calorie meal. Is to make the weight go up. I don't think it's for this class. I don't know. I'm just kind of rambling now. Just kind of things to keep in mind. What else is good? Okay, here's a good one. So here, when it comes to implementing the TPN, how do you start it? Like, yeah, slow, and then how do you wean it? Also slow. Yeah. And how come? Yeah. So we're starting it slow to prevent hyperglycemia, and we're weaning it slow to prevent hypoglycemia, right? That's your main thing. What do you do if you are your first TPN bag is about to run out and you're taking a bit to get the second bag? What can you give the patient while you're waiting? You're on the right track. It's not quite D50. Um, if you recall up here, the amount of dextrose in the TPN is usually 10%. So like a D10. Okay, what else can we do here? IM or IV? IV. Compare labels. What else? What else? Here, I'll add some extra stuff here. Oh, I already put that one down. Boop. So checking the labels. With TPN, you actually should do a second RN check. IQ checks every 6 hours. That's important to keep in mind. And something to keep in mind is that every 24 hours, the doctor makes changes to the TPN and gives a new order based on the lab results. Because maybe based on their lab results, we need to adjust some of the stuff that's happening in here. So every day is a new order for it and with new stuff in that TPN. And we talked about the labs, so I'm not gonna really harp too hard on it. Boom. Electrolytes, their albumin, because I remember their albumin can be an indicator of nutrition. If you give them too much protein, that can overwork the kidneys. Yeah, exactly. White blood cell count, because maybe they got like an infection, because remember they're at risk for CLABSI because they use a central line. And then the other one is like an ammonia level. The basic idea, and you'll learn more about this when we go over liver, is your amino acids get broken down into ammonia, and then your ammonia gets broken down to urea nitrogen, and then that gets peed out. So if we're stressing out the kidneys too much, then maybe we get stuck with the BUN being really high, or if we have problems with our liver, we get stuck with a lot of ammonia, as you'll learn more about. Other things to keep in mind is it probably, again, some of these are not like the most important things, well, that's why I didn't really ask about it as much, but it's just kind of getting the concept there. So should be refrigerated, change the tubing. We mentioned 24 hours. and then lipids Q12 hours. Actually, let me be specific. So lipids that are hung separately are changed Q12 hours. Sometimes they actually are together. Okay. We talked about central line, staying with the patient, administer at constant rate because of glucose levels. And we talked about D10W to maintain through a PIV. He mentions about the blood draw. I don't remember this coming up really, but just good information would be if you're trying to get a blood draw with TPN, you don't want to throw off the blood draw. So stop the TPN, wait a little bit, and then you're gonna discard a little bit of that blood and then take your blood draw. And then for documentation, I don't think they get asked directly, but it's just good information. Things such as their blood sugars, because remember you have to do AccuChecks, their eyes and nose, and their daily weights, because remember we're looking out for FBO, their vital signs as always, labs as always, because they're going to base the next order on that. You can note what is being given, assessment on the central line, when you change something, and then also like, yeah, when you change the tubing or flush the line or when you hung the TPN. And that's essentially everything. And if you guys want, I also have another like extra little thing right here. Basically, again, a little extra stuff. Honestly, I don't know, and the reason I don't know is because it's not tested and I don't remember. Don't worry about it. The filter stuff, don't worry about it. I think it is below because if you do it above, it gets clogged. Yeah. But again, don't worry about the filter for this class. That's pretty much everything. Any questions on anything that we went over? I know we went over a lot. And like I said, we're gonna go over hematology alongside the leadership stuff next week. All right. So there you guys go. Let me know if you have any questions. If something comes up later, was this straightforward? Honestly, I don't remember. I think it was all right. I think honestly, I think some of the harder questions were actually the delegation and prioritization questions. So you're definitely gonna want to know what your CNAs and LVNs can and cannot do, and yeah, and who you're gonna see first, which is again ABCs, what's gonna kill my patient first, kind of idea. Yeah. Yep. Have a good night.